Please go ahead.
Good
Yeah.
evening, doctors. So I am Dr. Amra Sheikh. I'm associated with Emcure Pharmaceuticals as the medical advisor. I welcome you all on this digital platform of No Thrombosis workshop series in stroke for another exciting session with our course directors, Dr. Ichaporia sir, and our esteemed speaker, Dr. Vinayak Jatale. Sir, thank you so much, sir, for joining the meeting. It gives me immense pleasure to welcome both of you. And with your kind permission, we can start the program.
Yes, let's start.
Yes, sir. So, should I make it full screen? Are my slides visible?
Yeah, just introduce Dr. Aarti.
Dr. Aarti,
Hello,
thank you so much, ma'am.
Dr. Aarti. Yeah, just introduce her, please.
Dr. Aarti, thank you so much, ma'am, for joining the meeting. And it gives me immense pleasure to welcome you. Ma'am is associated with several hospitals in Pune and Pune as well, ma'am. Pune as well.
New Mumbai.
Terna and Pune and Mumbai. So, ma'am is
that is New Mumbai, no?
Yes, your mic is off.
Yeah, put on your mic, Dr. Aarti. Yeah.
Sir, it would be better if I introduce myself. I think madam is not aware of me and she has not given my introduction also in the beginning. So as we have already met, sir, so many times and we have had shared the common platform. Basically at Kharghar, I have my neuro center, which is Arogyam Comprehensive Neurocare Center, which is a one-stop solution for all neurological ill patients. So I have neurophysiotherapy, psychiatry, neuro rehab, everything under one roof. And I'm practicing in Apollo, Medicover, Terna Group of Hospitals and MGM Group of Hospitals in Navi Mumbai. So that is my short introduction. We'll go ahead with the meeting. Thank you very much.
Just introduce Dr. Vinayak.
Yes, sir. Myself, Dr. Vinayak Jatale. I am a consultant neurology at Dooth Hospital, Aurangabad. Here I am practicing since last 1 year. I have just completed my DM neurology from AIIMS Rishikesh in the year 2020 to 2022. And currently we have started a comprehensive stroke care here at Dooth, and we are able to successfully lyse as many as patient, about 25-30 lysis in past 1 year, sir.
Okay. So, will you present your case?
Yes, sir. So, just how do I share my slides?
Yeah, share your screen.
Sir, at the below, there will be an icon for sharing the screen at the lower part of your laptop screen.
Yeah. Is it, are my slides visible?
No, not yet.
There will be a green icon, share icon will be there.
Yeah.
Yes, now it is visible, sir.
Yeah. Yes, sir. I will directly start now. My first case is, sir, a 44-year-old male. He's a known hypertension since last 5 years. He's a known case of CA lung with primary lung to vertebral mets and mediastinal mets. He's on regular chemotherapy. He's considered to be in remission. He also has significant history that he had pulmonary embolism 6 months ago. And he had due to this massive embolus, he also had underwent a CPR. He had an old left hemiparesis 2 years ago, and that recovered completely. And current MR score is 0, and is working as a clerk. He presented with the complaint of inability to speak and understand since 3 a.m. in the morning, and he presented to us at 8 a.m. In casualty, he was conscious. He was not able to speak as well as he was not able to understand any spoken words. He had a right arm and leg drift, and his NHS was 5 at presentation. So we directly went for imaging. After imaging, after shifting in ICU, he has
How was the NHS 5 only?
sir, with aphasia,
Two, two.
global aphasia, and there was a
Yeah,
mild
global aphasia is how much? 2, no?
3, sir.
3.
Yes, sir.
And
And
drift
drift of
is
both sides. Only mild drift was there, sir. When he presented,
leg also, no?
yes, sir, both.
Yeah, maybe little more.
Uh,
Okay.
But he rapidly worsened, sir. Within next 40 minutes, he became unconscious with severe right hemiparesis, and his NHS progressed to 23 within next 40 minutes, sir. So now he was unconscious. There was not able to respond to any command. There was severe weakness with facial involvement and aphasia, sir. So he progressed to around 23 in the span of 45 minutes, sir. So this was this presentation MRI in axial diffusion weighted imaging. In Sylvian fissure, we can see a pelvis inward diffusion weighted changes, sir. And there is an old gliotic region in the right hyperparietal region. In comparison to the T2 images, there was no enhancement, no changes seen in the T2 images. And in angio, we can see that there is a cutoff from the MCA territory. So there was a diffusion flare mismatch in this case, and there was a large vessel obstruction also. Coming to the angio images, we can see that there is a paucity of flow from the main M1 territory, sir. We can see it clearly here from the left MCA. After bifurcation, there was a complete cutoff from the M1 territory. Very well seen here, sir. Main concern was his onset was around 3 a.m. and he presented to us beyond a standard time of 4.5 hours. It was difficult explaining the oncologist because the patient had prior so many events, including post-CPR status pulmonary embolism, old stroke, and remission from his CL lung to multiple meds, and explained that the bleeding risk is around 2% to the physician as well as intensivist. So this was his current cancer status. So 6 months ago, he had this primary lung lesion with multiple mediastinal mets, vertebral mets, and lymph node involvement. By July, he has underwent into remission. There was only some part of mediastinal involvement and vertebral involvement. So we had a positive point that he was in remission. So we, after due Harris consent, we thrombolized him with 1080 place. He was 85 kg lad with 17 mg 1080 place. There was no worsening hourly monitoring, and his NIHS sensorium improved in 1 hour, and his NIHS improved to 10 from 23 in a period of 24 hours, sir. This was his post-lysis images. In this, we can see there is no bleeding first thing, and there is a post-lysis changes, some part of changes here, as well as we can see there is a cortical mild enhancement.
Enhancement.
Enhancement or mild changes, sir. Mild edema we can see on this side, sir. But there is no bleed, sir. By discharge on day 5, sir, his NHS has improved to 6 from 23. He had a conduction aphasia on discharge, and MRS score was 1 on discharge. This is his status.
This is patient Balasan Kai. He had a stroke. Walk. Move his arms. Okay. Speak, but now he has been improving his speech. Now, sir.
So here we have this case, patient with old CA lung in remission with multiple mets, with multiple comorbidities, with history of pulmonary embolism, who presented with a severe stroke, and he successfully responded to thrombolytic therapy, and now he's able to do his job as usual like before. This was my first case, sir. In this, to have a literature supporting our case that thrombolysis in acute ischemic stroke in patient with cancer, this AHA guideline says that use of thrombolytic therapy as well as mechanical thrombectomy has increased over the past decade in patients with cancer, and the current frequency, as per the study, the mechanical thrombectomy use has also been more in patients with cancer because they might have a propensity of large vessel obstruction more severe. So, like other risk factor like diabetes, hypertension, independent cancer is also considered as a risk factor for stroke now. So, may I start with case 2, sir?
No, wait. Dr. Aarti, do you want to
Yes, sir.
say something?
So definitely it is a what you call it's one of the difficult cases or maybe the gray area of thrombolysis when the patient has diffusion perfusion mismatch, high NIHS, large vessel occlusion, and out of window period patients presented to us, and there is a rapid worsening and deterioration. So was the mechanical was tried or maybe the call was given, sir, for the mechanical in this patient?
No, ma'am. Mechanical call was not given because of two reasons. One was affordability of the patient, and second was, ma'am, he had good
Okay.
following the lysis. So we did not give a call.
Mm-hmm.
We went ahead with the mechanical thrombectomy.
And post-stroke recovery, any repeat imaging showed any resolution or any stenosis persistent in the M1? So any repeat imaging at the end of maybe 6 weeks, 8 weeks, anything has been done? Just for a prognostication of future recurrence.
Just 1 month has passed, ma'am. Since this lysis, we have not done a repeat angio. We'll surely get it done, ma'am.
I think we should get it done. And if it is still stenos, maybe the DSA would be the better option.
Okay,
Just
ma'am.
to go for and to analyze the anatomy. And patient should be on the dual antiplatelets. Definitely the cancer with the stroke thrombolysis, especially if there are no intracranial metastasis, we can go ahead, provided everything is in the favor of doing thrombolysis. And in your case, the patient has given very well response. Sir, you, HFS, you want to say anything about this patient? Means any further discussion?
Yeah, see, first of
From
all,
your side.
This illustrates a number of points.
Yes.
The point number one is that, even if NIHSS is very high, 25, you can thrombolize these patients. Previously it was said that very severe strokes don't do well with IVT. But that is now given up. And if even if it is a large stroke with NIHS, the patient was unconscious. So the NIHS more than 25, you can't even measure it actually. So so even in large strokes and severe strokes, IV thrombolysis is helpful. Previously, we used to reject these cases, but not anymore. Secondly, many times we find many times, maybe 40%, 50%, large vessel occlusion in M1 also opens up with IV tenecteplase. The interventionists, they fight with me and they think that I'm joking and telling lies, but I'm not. I never tell lies. Many times we have found, even on this forum, that TNK is the drug of choice for LVO. And many times M1 to 40%, maybe even 50%, 40% was the old number. In ICA, maybe it doesn't open, but M1, M2, many times I have seen that it opens. So this very clearly demonstrates that this patient has done so well with only IVT. And, we say that, no, you must do mechanical. And I'm also very much in favor of doing mechanical, and we don't want to wait. But many places in our country and even in our center, we have great difficulty in doing MT because of the cost factor.
Yes.
So we find that IV tenecteplase is extremely effective, and in a large number of patients, it improves. And very clearly, he has shown that, this patient was outside the 4.5-hour window period, but there was a clear diffusion flare mismatch. And the diffusion lesion was also not large. It was small. It was not covering a large part of the MCA. So probably there was a big penumbra. The penumbra, because the penumbra increased in size, the patient worsened so much and his NIHSS went up. It was not infarction. So the core of the infarct was relatively small, where the diffusion, this thing. And many times we have seen that even that diffusion shrinks after the patient improves. Diffusion is not, we think that it is a surrogate marker of infarction, but it may overestimate the size of the core, especially if it is done early. So even that diffusion thing can reduce, and clearly there was nothing on flare. So many congratulations for you to take up this case very boldly, I must say, and you have done a fantastic job.
Yeah,
now,
thank you, sir.
The risk of stroke with cancer is high, and some people say that Abhi, now this fellow had so many metastases, and if the person is not going to survive more than 6 months, you should not do thrombolysis. But now with targeted therapy, and this fellow is quite young, so I would not give up, in this case. Even though there are vertebral metastases, they can live for another few years, We don't know how long he's going to live. Nobody knows how long anyone is going to live, and they should not know also. So definitely, and a young, what is his age? 38, you said, no?
Yes, sir.
Yeah, 38. So young person, we must give him the opportunity. Now, in cancer-related stroke, one of the pointers is high D-dimer level. So did you do D-dimer?
No, sir, we have not done D-dimer.
So, high D-dimer level in cancer-associated stroke is important. And there is a point of view that maybe we should anticoagulate these patients rather than giving dual antiplatelet. So the jury is out, but because, it is a thrombotic event, it maybe it's not level 1 evidence, it may be level 2B or so, that anticoagulation would be preferred, but this is open to correction. I mean, I'm not being adamant, but perhaps because if D-dimer is high, means there is the degradation of fibrin, and it is a red clot, or it is a thrombotic clot, and there is definitely a prothrombotic state. Cancer is a prothrombotic state. So there may be a case for anticoagulation with warfarin, or maybe even NOACs. I mean, there's no proper data yet. So that point is little vague, but the important thing that Dr. Vinayak has done is he was aggressive. He used the diffusion flare mismatch. Even though the patient was so bad, he had the guts to give TNK, and lo and behold, it's a miracle.
Yes,
so, like these, you see so many miracles now. Miracles, these are miracles, yeah. These are miracles. And many times we see in thrombolysis, IV thrombolysis, these patients do so well. And within a month, I think his MRS is 0 or 1 maybe. Yeah. And NIHS dropped very rapidly from 25 plus. I don't know if he's unconscious, it's 25, it's maybe 40 also. So, from that level, it dropped to 6 or 5 or whatever. It's a dramatic improvement. So I'm sure the MCA has opened up. I mean, for academic purposes, we would like to see an MR angio or a CT angio. But that is academic. See, money is a problem. Patients are not willing. You also don't want to push too hard because, cancer treatment itself is so expensive. Families in distress. So don't push too hard, but if you can, do it.
Yes.
So, it helps us, but I wouldn't be adamant and I wouldn't be pushy to do an MR angio again and just see if that vessel, for our understanding. But, I understand that money is an issue and so many other issues. So I think that summarizes the case quite well. And excellent teaching for everyone.
Yes, sir.
Point 1, diffusion flare mismatch. Point 2, severe stroke can be treated. Very, very severe NIHSS can be treated. LVOs do open up with TNK. Cancer produces more incidence of stroke. And maybe we need to use anticoagulation, maybe instead of DAPT.
Yes,
So
sir.
I think these few points are important, but you must have the guts to do this,
Yes.
and you'll be so happy to see patients like this, and I think he'll become friends with Vinayak for the rest of his life.
Yes, sir.
And maybe on Diwali he'll send
Very well
him.
managed case.
Yeah, on Diwali he'll send him a lot of sweets and dry fruits, and maybe
Yes,
a
sir.
bottle of whiskey also. Okay, chalo. Next case.
Yeah, yes, sir.
Arti, do you want to say something?
No, very well managed case, sir.
Yeah. Yeah, excellent.
Thank you.
Vinayak, next.
Yes, sir. Next is a small case, sir. 52-year-old female. She is a known hypertensive on regular medication. She also has some symptoms of, also had depression symptoms. She had 15 days history of paresthesia in left arm, hand. This paresthesia was persistent throughout the day and absent at night, but there was no weakness for those 15 days. And it was treated as CTS. On the day of Diwali morning at 10 a.m., she had, at around 10 a.m., she had difficulty in speaking and there was worsening of left arm symptoms. She reached hospital around 11:45 a.m. She was conscious. There was no aphasia. There was left lower facial weakness, and there was left arm mild drift. Left leg was normal. Sensory was normal. Her NHS was coming to 3 in the form of facial movements, drift, and mild dysarthria. So this was a minor stroke symptom. Vital showed only blood pressure of 150. There was no other symptom. So her diffusion weighted images was MRI was done urgently, and it showed a watershed what area changes in the watershed region of MCAC territory. Similar changes were seen in the T2 flare images. Small changes in the watershed region.
How many hours did she come in?
Sir, within 1 hour 45 minutes. Sir.
1 hour 45 minutes. Okay.
Yes,
yeah.
And but angio at the same moment showed a large vessel occlusion, sir. So this is the ICA bifurcation. The M1 MCA stem did not show any flow, and there was no absence of cortical blood supply, and there was some collateral blood flow. Showing the angio from other side, we can see ICA bifurcation, and the M1 stem, there is no flow forward beyond this.
M1?
M stem, sir. MCA,
So
sir.
there is a small, lengthwise small clot, no?
Yes.
But
there is
is that correct?
I think so. There is a cutoff from the MC, sir. MC stem, sir. Here, sir.
Yeah, but there is some distal flow.
Yeah, there is some distal flow, sir.
But not good flow.
Yes, sir.
Mild flow.
Mild flow, sir.
Yeah.
Yes, sir. And so with this low NH, so this was a 43-year-old female hypertensive.
No, wait.
Yes, sir.
Are you thinking of artery to artery embolus, or are you thinking of hemodynamic stroke, or what? It's in the watershed area, you said, no?
Yes, sir. It was in a watershed area. So it was a hemodynamic stroke at that moment.
No, not all watersheds are hemodynamic. It could still be artery to artery. Whenever you get watershed infarct, no,
So,
you must think of LVO.
okay, sir.
You must think of MCA
Definitely.
or ICA LVO.
Okay, sir.
Now, some of them are artery to artery emboli, and some of them are hemodynamic. Now the jury is out, whether they are hemodynamic or whether they are this thing. So, you can't really, I mean, I think somewhere I read, keep it is external watershed. It is, I'm also forgetting, it is embolic, and internal watershed, it is hemodynamic. So what is this, internal or external?
And this is external, sir.
Show
Between the
that MRI picture again.
Yes, sir.
Yeah, just can you enlarge it a bit?
Yes, sir.
So there is a string of pearls, no? Let me
Yes,
see.
sir.
Just go this way. Just go to the diffusion part. Diffusion, yeah. Yeah. Just
Yes.
enlarge that. Yeah. Is there a string? It looks like external watershed.
Yes, sir.
Okay. So this is a classical case of low NHSS
Yes,
with
Yes, sir.
LVO.
LVO. Yes, sir.
So now what is the thing to do with low NHSS but with LVO?
LVO. Yes,
Yeah.
sir. That was
Now,
our
now continue.
in our center, sir, if any patient of stroke comes, so first thing we offer is IVT, sir, thrombolysis, and then after thrombolysis we go for if there is a need for intervention. So in this case also, it was difficult to explain them that the such minor symptoms can be a large stroke later on. But with the imaging, we had a support that we were able to tell that there is a no blood flow in the MC territory, so patient can worsen. So this patient requires thrombolysis. So with that consensus, we thrombolized the patient. We lysed her with 10 actiplase, 14 mg, with door to needle time of 43 minutes, sir. And within 5 hours, her symptoms all NHS of 3 came down to 0, sir. There was no further worsening. And her imaging also did not show any presence of bleed, and there was neither any infected tissue, sir. So further, we planned for intervention. We got a neuro intervention call and planned a DSA on day 3. But day 3, patient again started complaining of symptoms of left arm paresthesia. At that time, there was no weakness. Blood pressure was 148/88. So we wanted to rule out a repeat stroke. There was no weakness, but just to make sure that the patient has not worsened because of the vascular event, we got a repeat imaging done. Repeat imaging did not show any infarct, neither in T2, neither in diffusion. But luckily, we got the top angio done with MRI, which showed that the vessel has completely opened up the MCA territory. So the symptom that the patient developed on day 3 was because of her depression associated, because of some event in the family that happened after the stroke also, that patient started complaining of the symptom, but there was no worsening or repeat stroke. But luckily, we were able to establish that the MCA vessel that we lysed has completely opened up. So there was no further focal deficit. Her blood pressure was maintained 140/96. We prescribed her SSRI with dual antiplatelet. Patient further refused for DSA and she was discharged after this.
Why do you want DSA?
Sir, because of her, before this imaging, we planned DSA for whether the patient requires assessment of a large vessel, sir.
But you have seen the large vessel, no, on MRA.
Yes, sir.
And the flow is good, going right up to the periphery.
Yes, sir. Yes, sir.
Maybe
You don't
that
need a
vessel is completely
DSA.
opened up after thrombolysis.
Yeah.
Yes, sir.
So the angio is
So,
clear.
this, sorry, Arti, please continue.
I think post thrombolysis, the vessel has opened up, sir, completely.
Yes.
The angio is looking beautiful.
Yes.
Maybe DSA
Yes,
is not needed in this
Yes,
presentation.
Yes.
No, so this point, this case demonstrates what you should do with low NHSS, but with LBO.
Yes,
The
sir.
consensus of opinion is at present that you should give IVT, and if there is further worsening, then go in for MT. But don't go in for MT straight away because it does not give benefit.
Okay,
So
sir.
that is the general consensus. It may change over a period of time. But consensus of opinion just now is that LVO with low NIHSS do IBT and observe the patient, of course, carefully. And if you find that there is worsening, then go in for a rescue MT.
MT.
But don't go directly for MT, because MT also, it has its risks. It has a cost factor. And
Yes, sir.
if it was risk-free, yes, I would do it. But it's not risk-free. So, and don't deny this patient. We say the low NIHSS, don't do anything. Don't give IBT.
Yes.
But low NIHSS with LVO, you should give IBT.
MT. Yes.
Okay. So if it is low NIHSS with, say, a lacunar infarct or a distal, some, M3, M4, I suppose, then maybe you would not, and very, very minor symptoms, no disabling. So low NIHSS with non-disabling stroke. Okay. So it can be low NIHSS with disabling
symptoms.
So low NIHSS with disabling symptoms, you will thrombolize. But
yes,
low NIHSS with non-disabling symptoms like this little paresthesia, maybe you would not. But if there is an LVO, then you should.
Then you should, yes.
So, this is how you distinguish between the things. And
Yes.
There is no hard and fast rule. I think each patient you have to study properly, think about it. And again, this shows very beautifully that LVO opens up with TNK.
Yes, sir.
I've been saying this for years, and people are shouting me down and saying that you're an idiot and you're against MT. But I'm not against MT. I'm just saying that, the IBT works so well in so many patients, so give them the benefit now. You are saving so much resources. You can do this in the periphery. You don't need a cath lab. You don't need to call the interventionist. You're easily saving 7 to 8 lakh rupees.
Yes.
It has all the advantages on earth. Why the hell should you not do it?
Yes,
okay, sir. If it doesn't work, then do it. Yeah, who's saying don't do it? I'm not against it. But many times we have found that it does work beautifully. So
yes, sir,
that is one. And on this forum, in this no thrombosis forum, many people have presented cases. Many people have presented MCA occlusion, M1, and they have opened up with IVT. And of course, I have also seen many patients improving. So I would urge everyone not to not do it. Just do it. Do it. Be bold. Do it. Nothing is lost. Even, okay, you may lose a few thousand rupees here and there, but there is everything to gain. Risk of hemorrhage is extremely low. Extreme. So don't worry about hemorrhage. Okay. So just do it whenever you have a lesion like this. LVO. This is a clear LVO, but here the clot is small. If the clot is long, maybe 8 millimeters and more, if it's a soft clot like this and small clot, less than 8 millimeters in length, then the TPA can penetrate, the TNK can penetrate into the clot. So it is a porous clot. So here there is distal flow. So probably it is a porous clot. So the TNK is going through the porous clot. And because it's going through the porous clot, it can dissolve the clot. If the clot is hard and there is just no flow, then it will only act on the surface. TNK will only act on the surface. So it may not be able to dissolve the clot. But if the clot is porous and little bit of TNK is going in, it can dissolve the clot. So this appears to be a porous clot, and it is a small clot. I mean, clot length and clot mass is less. And therefore, this response has been so excellent. So many things to learn from this case. I mean, it is straightforward, and patient did well, but so many small things are there to learn in this, So this is a continuous learning process. Aarti?
Definitely in this case, what you said, sir, that is absolutely correct. And in my practice also, I'm always worried about this large artery occlusion. So whenever there is LO, large artery occlusion is there. So always it's better to go ahead with thrombolysis if patient is reaching to the neurologist. It is our job to thrombolize the patient in order to prevent future worsening. Sometimes initial 1-2 hours they do well, and about 4 hours, 4.5 later on they start worsening. Maybe if you're not thrombolizing on time, that window also goes off for thrombolizing patient within the time, and the patient starts worsening, and then we don't have any other options left besides mechanical thrombectomy. So if the patient is reaching within the time, it is better to thrombolize such patients, especially when the large vessel is occluded and the NIHS is low and the infarct size is small. The risk of bleeding complication is also less. I have never seen any of my patients bleeding because of thrombolysis in such scenarios.
Bleed, I feel that TNK bleeds, have become much less. Maybe, we are controlling BP better, we are selecting our patients better. So I don't think this bleeding thing now should come in the equation. I mean, we should be bold. Everyone's scared कि अरे bleeding होएगा तो साला court में जाना पड़ेगा. नहीं, that never happens. That never happens. So don't worry about bleeding. Even in stroke mimics, sometimes you can't be sure. Not stroke mimic comes, it's a migraine aura, or it's post-ictal, or it's functional. Sometimes they are in the middle of the night. You are so uncertain. You are also not in proper senses to make a decision. So I would say thrombolize these stroke mimics also, because no harm will occur. The risk of hemorrhage is extremely low, maybe 0.5%. Not 0.5%, so extremely low. And, if it is a stroke, definitely they will benefit. So stroke mimics, I think you need little more study, in the sense that you need to do an angio. You need to, I think every patient we should do an angio, either MRI angio or CT.
Definitely, yes.
Yes.
But Vinayak, why did you prefer MRI rather than CT? He came
Sir,
in window, no? I mean,
yes,
he
sir.
was in window.
Yes, sir. Actually, MRI I prefer because to make the patient explain the lesion.
What do you want to explain here? See, you're wasting another 20 minutes.
Yes, sir, I understand.
Okay. So there is nothing to explain.
Sir,
The commonest CT finding in stroke is a normal CT scan.
normal CT scan. Yes,
It is the mismatch between the CT scan and the clinical picture.
clinical picture.
That is the mismatch. So don't worry about this.
Yes, sir.
Okay, here definitely it was beneficial, because you found a border zone, what do you call it?
Large vessel occlusions.
This infarct. You found a watershed infarct. So, but otherwise, if he comes within 1 hour, you do it and do a CT angio, you'll find this thing and just thrombolize these fellows.
Yes, sir.
Okay.
Sure,
So
sir.
well done once again.
Yeah, thank you.
Well
sir.
done.
Yeah, thank you, sir.
Yeah. Any other case?
No, sir, these two cases. Sorry.
Okay. Dr. Aarti, would you like to sum up?
Yeah, yes. I will just share my clinical experience, sir. Like in the first case, what sir had shown. So I had similar patient. We did the patient in that case, we had done, I think, IV thrombolysis followed by mechanical thrombectomy. So the what you call the diffusion perfusion mismatch. So post IV, we had to go for a mechanical thrombectomy because the occlusion was at the ICA level and the patient had a left MCA territory stroke. But post mechanical thrombectomy, patient had a bleed, not post IV thrombolysis. So I end up seeing maybe, I think, a lot of patients post mechanical, they're having hemorrhagic transformation of infarct. Sometimes we are just giving IV thrombolysis, patients are not bleeding. But if we are subjecting them for mechanical thrombectomy in the large vessel occlusion, they're having hemorrhagic transformation and further deterioration. So what is your opinion and what is your take on this? I just had this doubt I wanted to discuss since long.
Maybe what happened, hemorrhagic, but was it a PH2, symptomatic ICH?
Yes, definitely. Means mass effect, then we had to do the craniotomy for that patient, tracheostomy,
it was a
everything.
PH2, no?
Yeah, yes.
No, I don't think I've seen increased risk of symptomatic ICH after MT I don't think I would say that. I would say the risk is about the same. It just happens maybe the vessel opened up rapidly and there was a surge of blood pressure. But I don't think there's increased risk. And if you don't open up the vessel, then with either IVT or MT, then also the person will do badly, and maybe he would require decompressive craniectomy even then. So, don't worry about this thing. If the vessel did not open, he would have had a large MCA infarct and you would have to decompress him. So now he got a hemorrhage and you decompress him. I mean, we don't want hemorrhage to occur. Obviously, we don't want. But if it occurs, it doesn't, worsen the prognosis to that extent, unless it's massive. It's massive going into brainstem, medulla, here, there, intraventricular, then you can't do a damn thing. But if it is localized to the infarcted area, then decompressive craniectomy often it helps. And if you had not opened also, you would have had to do decompressive craniectomy. So look at it that way.
Okay.
Look at it that way.
Yes.
Yeah.
Definitely. Just to summarize, sir, maybe.
Yeah.
The patient, those who have diffusion perfusion mismatch, ideal candidates, maybe the neurologist is the best person to decide about the IV thrombolysis. Patients with large vessel occlusion, tenecteplase really does wonders with the less bleeding risk. Patient has low NIHS, but the large vessel occlusion, definitely we should go for thrombolysis if they're presenting to us within the time frame of 4.5 hours. It is better to thrombolize them in order to prevent the further deterioration, explaining them the risk and the benefits, and understanding every patient is different. So understanding the risk and the benefits associated with thrombolysis and explaining them to the patient and gaining their trust is also important. I think both cases are the excellent example of how the neurologist can manage patients beautifully by giving IV thrombolysis on time.
Absolutely.
So the first case and the second case, both cases are managed very well.
Extremely well. Yes, well summarized, Dr. Aarti. Really well summarized. And once again, thank you, Dr. Vinayak. Well done.
Thank you, sir.
And keep it up.
Yeah, sure, sir.
Thank you,
Lage raho.
Yeah,
You have
sure,
to do.
sir.
You have to make centuries every year.
Sure, sir.
You have just started your career, so every year century marne ka, or maybe even double century.
Sure,
Okay.
sir. I want it, sir. Yeah.
Yes, Dr. Namra. You can't hear.
Thank you so much, sir. It is always an educational feast to hear from you now and every time. As and when I've been associated with this workshop series, you've always been a great inspiration. And I would take some time to reintroduce our esteemed faculty for today's session. As we all know, our course director for today's session, Dr. Ichaporia, sir.
How many times you're going to introduce Namra now? Enough? No, yeah. How many times you're going to introduce?
Sir is great in thrombolizing patients and he's a pioneer in thrombolysis treatment. Just another short introduction of ma'am. So ma'am is associated with Arogram Comprehensive.
I think I have already introduced myself.
Yeah.
So ma'am, such a pleasure to have you on this forum.
Yeah.
And our speaker, Dr. Vinayak Jatale, sir. Thank you so much for being on board today, sir. Sir is associated with the Seth Nandlal Youth Hospital in Aurangabad, Maharashtra. And for today's session, I would like to thank Dr. Ichaporia sir, Dr. Aarti Kulkarni ma'am, and Dr. Vinayak Jatale sir for making time for this meeting. It was a great and insightful meeting. We came to know several things like even severe strokes can be thrombolized. They should be thrombolized. And patients with low NIHSS and disabling stroke, they should also be, it is good to thrombolize them. And several other scientific insights we got through the workshop. Sir, with this, I would like to close the session. So with your permission, I would like to close the session.
There is a
How
question.
many attendees, Namra, this time?
Sir, today we are live with 180 attendees.
180. Okay.
Yes, sir. There's just a question which popped up in the chat box.
Yeah.
So the question is from Dr. Tushar Desai. He says, what to do in operated brain tumor, recent versus remote, having ischemic stroke, lysis or empty?
Say that again.
What to do in operated brain tumor, recent versus remote, having ischemic stroke, lysis or empty karna chahiye? What to do between the two?
Operated for what? Brain tumor.
Yes, sir.
Then we are always a little scared, We'll have to really assess whether the stroke is because of the brain tumor or it's really a stroke. But if it is really remote, then, and it was a benign tumor, if it was a glioma, then I would not thrombolize. Because, they can bleed. Those vessels are very fragile. But if it was a meningioma, and the meningioma has been removed, or it was an acoustic neuroma, or a pituitary tumor, or if an aneurysm has been clipped or coiled and isolated, then I think we can thrombolize. But if it is an in parenchymal tumor, like a glioma, then no, I wouldn't thrombolize these patients. Okay?
Thank you, sir. Thank you so much.
Okay, bye. Good night. Good night.
Thank you, sir. Thank you. Good night, sir.
Thank you, sir. Good night.
Good night. Bye.
Good night, sir. Good night, ma'am.